Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Welcome to Mad in America Radio. My name is Bob Whitaker, and today my guest is Italian psychiatrist Giovanni Fava. Now, before we begin, I'd like to take a few moments and explain to our listeners the context for this interview. From 1992 to 2022, Dr. Fava edited the journal Psychotherapy and Psychosomatics. We are going to be talking about the importance of that journal and what may be lost now that the publisher, Karger, may be taking it in a new direction. Here's why this journal, under Dr. Fava's leadership, was so important to us all. When psychiatry talks about how its drug treatments are evidence-based, it points to RCTs and meta-analyses of those RCTs as proof that its drugs are more effective than placebo. However, Psychotherapy and Psychosomatics, under Dr. Fava's guidance, presented a very different evidence base to its readers. First, his journal told of how clinical experiences should govern our understanding of the impact of psychiatric treatments, particularly over longer periods of time. Second, his journal told of how RCTs and meta-analyses, when used to direct clinical practices, can lead to harm. Third, his journal told of the corrupting influence of pharmaceutical money on the creation of psychiatric diagnoses and drug trials. Now, when Dr. Fava became editor of Psychotherapy and Psychosomatics in 1992, it had a low impact factor. When he resigned as editor in 2022, it had an impact factor that made it one of the most influential journals in psychiatry and psychology. He left the journal in good hands in 2022, and he remained involved as an honorary editor. However, in December, Karger fired one of the two editors-in-chief. Dr. Fava then resigned as honorary editor, and most of the editorial board resigned as well. So the future of this journal, which had been so essential to our understanding of the impact of psychiatric treatments, is now unclear. Welcome to Mad in America Radio, Dr. Fava.
Thank you.
So I have a first question that may seem a little simple. The title of your journal was Psychotherapy and Psychosomatics. I'm not sure everybody understands what the term psychosomatics mean. Can you just explain what that means?
Psychosomatic medicine is a movement that originated in medicine about 50, 60 years ago. And it tries to consider the person as a body-mind unity using the scientific methods that apply to medical research. It has always been a field of pioneers, independent thinkers, and one of the most important people in American psychosomatic medicine has been George Engel, who, by the way, was also my teacher. I spent a summer with him while a medical student. And this model, which is recognized, the biopsychosocial model, which is recognized all over the world.
One key thing here is when you talked about independent thinking. I know a little bit about the work of Dr. Engel, so obviously you have displayed that for a long time. Now, you become editor in 1992 of Psychotherapy and Psychosomatics, and you bring to that position years of clinical experience, and I think in particular working with patients with mood disorders. So how did that clinical experience inform your thinking about what you would like to see in your journal?
When I became an editor of this journal, I didn't know exactly what I was going to face in the following years. And really, if we go back to the 30 years, very long time, being an editor, there is pretty much a story of the development, the changes in research and in publishing. Going back to your question, something that I realized very soon is that in the 90s, the number of investigators who had familiarity with the clinical process was limited. In other words, you find people who publish about clinical matters, who give lectures, who teach, but these people wouldn't know how to treat a patient in practice. They don't have access to clinical practice, which is exactly the contrary of what I've been doing. I always had, this was one of the Rochester teachings, a busy clinical practice. So I could see what was going on in the real world.
So, research that is divorced from patient contact or patient knowledge seems like it's destined to be sort of blind to the real world if you don't have that clinical experience.
Right. And remember that the number of researchers who have no familiarity with the clinical process has increased tremendously over the years. All the research aspects that I've been dealing with in my career as an investigator, the source came from clinical practice, the ideas, the hypotheses, and were rooted in my clinical practice. If you don't have that, you end up doing studies that may be elegant, that may be rigorous, but they have really no relevance to what the clinicians have to do.
Now, in 1994, you write an editorial, and I remember when I read it, it was such a revelation, so to speak, that this this concern had arisen. You write an editorial suggesting, is it possible that antidepressants may worsen the long-term course of depression? Now, at the same time, here at least in the United States, and I think this is somewhat globally true, we were hearing of SSRI antidepressants that fix chemical imbalances, were breakthrough medications, and could even make you feel better than well. So now this is an example where we see two contrasting narratives around a class of drugs. So can you explain how you came up with that and why there's this incredible difference between the research story and the question you're raising at this time?
In my clinical practice, I had observed a number of phenomena which were kind of intriguing. Withdrawal syndromes were part of this phenomena, but there were also other clinical aspects such as loss of clinical effect and so on. So I decided to write down an editorial where I didn't have any conclusion, any firm statement to share, but I was raising doubts about certain issues. And you see, what was available, what was present in those days was something that is really one of the most important ingredients of scientific research, that is intellectual freedom, which many researchers do not have. They've lost because of ties and so on. So I wrote that editorial, but in many journals, in most of the journals, I must say, those issues were forbidden. Bob, I was, of course, very happy to see that in your breakthrough book, Anatomy of an Epidemic, you dedicated one chapter to the questions that were raised, because it's important to have those discussions. In those days, I must say that I had total intellectual freedom.
Well, two things. For me, reading that editorial legitimized something that I was trying to do with Anatomy of an Epidemic, which was investigate whether classes of psychiatric drugs on the whole might be worsening aggregate outcomes. And then when I came upon your editorial, first of all, it legitimized the question. And then, of course, we also saw among the American psychiatrists an effort, as you say, to silence that. We're not going to investigate it. And at this time in the United States, if you looked at mood disorders experts in academic psychiatry, virtually they were all taking consulting money from the pharmaceutical industry, which of course compromised their intellectual freedom, which you were not compromised by. So just to follow this, you raised this question, but you didn't let it drop, even though I think Donald Klein said, stop investigating it. You kept going at it. And as you did, you brought more evidence, sort of clinical observations to support your sort of thought that this indeed is happening. And finally, you came forth with a biological explanation or hypothesis as to why this might be so. Can you explain what that hypothesis was and what is the possible biological mechanism for this worsening of outcomes?
As a clinician, there were things which I was observing. One was the withdrawal effects of antidepressants. So I saw there were withdrawal reactions. At the beginning, those reactions were called withdrawal. But then, as you describe, Big Pharma intervened and then just said, okay, you have to call them discontinuation syndromes. And then there was the fact that in certain patients, these symptoms did not fade away after a few weeks, but became chronic, persistent. And then I put together this phenomena with other phenomena related to antidepressants, and that have been reported in the literature. One thing is that you give an antidepressant, for instance, to a young woman who's suffering from an anxiety disorder, and then never had a history of a bipolar disorder, and then she becomes hypomanic or manic. At that point, you think, okay, I made a mistake. Let's stop the antidepressant. Everything will go back to the point it was. It doesn't. In many cases, it doesn't. Then loss of clinical effects. At the beginning of the new millennium, we publish two very important papers by psychopharmacologists in a drug trial where it was shown that in about 1/3 of cases of patients on long-term treatment develop a loss of clinical effect. The patient taking the antidepressant, but it stops working. Other patients, you stop the antidepressant, it works. After a few months, you prescribe it again, it no longer works. So the issue for me was, what's going on here? You have all these phenomena. And then I use a theory which had been outlined in other fields, which is the oppositional model of tolerance. You see, tolerance is a word that you're not supposed to use in respectful journals. What does it mean? Is the fact that with a treatment, whatever treatment, it has some effects. But as treatment goes on, after a few months, it may trigger other effects which counteract the initial one and produce certain side effects. And when you stop treatment, these counteracting effects become predominant. So you have withdrawal, you have persistent symptoms, you have a number of clinical phenomena. And this, of course, was just a theory. But another teaching of George Engel was the fact that a theory is important not in itself, but to the extent that it may explain something that you encounter clinically. And my model could explain all these different issues. So I started with the editorial, and then we kept on publishing important papers. We published really the first paper by David Healy on SSRI and suicide. We published the first report on persistent sexual side effects. First is something that we did quite frequently. Again, in a time of where I could actually do whatever I felt ethically right to do.
As you know, Martin Harrell, when he did his long-term outcome study of schizophrenia patients and was looking to explain why the outcomes were better for those off medication long-term, he began looking at oppositional tolerance as an example of why it may make some patients, psychotic patients, more psychotic over the long term. So you see that explanation, and maybe it's just a hypothesis, but it is one that sort of provides a possible explanation for what you're clinically seeing. I have to say, the other interesting thing here is, I'm obviously not a clinician, but as a reporter, I would talk to a lot of people who took these medications. And the story that you were repeating here or telling here was very close to what they were telling me. I can't get off these drugs. I can't get my sexual function back. I'm depressed all the time. So it's interesting that even just listening to the patient's stories, which is a little bit like clinical experience, you get this other narrative that comes out.
Right. You see, many researchers subscribe to an idealistic theory that really makes no sense. The fact that you give a medication, you do something, you take it away, and everything goes back to normal. The pre-intervention. And what I've always been trying to explain to my patients, there is no way back. You cannot go back, but you can go forward. As recovery is a one-way street where you need to get a better balance, but not thinking of going back.
2000, I think it was 11. You write maybe one of your final papers about this. Then Riefel Malik writes a similar paper in, I think it was Medical Hypotheses. He labels it drug-induced tardive dysphoria. Also says it may be a mechanism similar to other psychiatric drugs. So my question to you is now, you became an impactful journal. You were setting this forth. Did you think this idea, this thought, did it enter the larger consciousness of prescribers?
It did, but it took a very long time for people to recognize certain phenomena. Let me give you this example. The journal became also a psychopharmacology journal because we were willing to publish papers, studies that other journals would never publish. And let me give you an example. In the late 90s, I was in Buffalo, New York, and I was in a bookstore. I was looking at a magazine where there was a journalist who was writing about conflict of interest and mentioning a study done by a professor of social sciences in Boston, Sheldon Krimsky. I look at the various databases and couldn't find a study. So I wrote to Krimsky saying, okay, I cannot find the study. Could you send it to me? And he wrote a very nice letter back. And he couldn't find the study because no one wanted to publish this study. And this was a major investigation that started the issue of conflict of interest. What they did is that they took the Boston authors and their disclosure of conflict of interest in the papers, but checked with what was available, what they could check more than like a journalist checking the facts, and find that 1/3 of the authors in major scientific journals had important conflicts of interest. So I said, submit it to me. It will be peer reviewed, of course, but if the methodology is fine, we'll publish it, which we did. And that paper should have been published in Nature or Science, not in Psychotherapy and Psychosomatics.
I happen to know a little bit about the background of that paper. I think Lisa Cosgrove was one of the co-authors, and they submitted it to other journals, and of course, it didn't find a home. This is one of the reasons that psychotherapy and psychosomatics, if it takes a different direction, it'll be such a loss.
Let me just mention the attitude of the publisher. And Thomas Karger, who was this publisher in Switzerland, told me, I'd like to see if the paper gets in magazine, newspapers. That paper by Krinsky and Cosgrove got an entire page of the Washington Post. Today, it would no longer be possible, of course, but we're talking about 20 years ago, it was possible. And so I sent the page to Thomas Karger, and he wrote me a very brief note. I'm proud to be your publisher.
Wow.
Those were the days. going back to your question, we continue publishing papers on this issue of antidepressant drugs and other psychotropic drugs. And see, the journal became sort of reference to investigators not being tied to the industry, had trouble publishing their papers. And one of these was, and still is, Guy Chouinard, one of the most important clinical psychopharmacologists, introduced at least 10 different psychotropic drugs in clinical use, and is author of the theory of supersensitivity psychosis, which again is not a very popular theory with antipsychotics. So we started this collaboration together. And in 2015, we published the first systematic review on withdrawal effects of SSRI. And there was an editorial by Guy Chouinard commenting on the findings. And I must say, that systematic review, which was the first, Michael and Gartner commented on that review, said it comes after 200 systematic reviews on the benefits of antidepressant drugs. So 200 against one. Okay, but that one, sometimes made an effect, and people started considering these. And for instance, I was pleasantly surprised to see that in the UK, the updated NICE guidelines started talking about withdrawal again, citing our systematic reviews. So it means that you publish certain things, and after a while, you can see an effect.
I first came upon Guy Chouinard and when he was writing about dopamine supersensitivity in like the early 1980s. And when I saw that he was on your editorial board, and I remember that article when he wrote and all, it showed how it was a home for this type of thinking. It made it so valuable. You said there was 200 RCTs in essence saying these drugs worked, and now you have this line. Can you just summarize why RCTs in essence can lead us astray and can lead clinical practice astray?
Randomized controlled trials are a very important part of clinical science, but we should not forget that the results of randomized controlled trials apply to the average patient, and they may not apply to all clinical cases. Let me just mention a fantastic study that was done about 30 years ago by Yale investigators, and they found that treatment, in that case was beta blockers after myocardial infarction, can induce improvement in a subgroup of patients, no change in another subgroup, and make things worse in another small subgroup. What is the problem? You just talk about the average. And particularly the third subgroup, you don't want to hear about it. But this applies also to psychotherapy. We had major problems in disclosing side effects of psychotherapy, which was another major aspect of the journal's activities, randomized controlled trials concerned with psychotherapy.
Yeah, I think especially with psychological psychiatric disorders, that's what you see. You see some people do well with the treatment, some people not so well. I mean, some people it just doesn't seem to make a difference, and then some people worsen. But as you say, RCT leads to one practice for everybody, basically.
Right. In a way, evidence-based medicine has degraded clinical practice. So what I mean is that with this idea that you have directions, guidelines that apply to everyone, whereas it is the clinical judgment of the clinician who has to interpret those guidelines. But clinical judgment means independence, means not following orders, not following guidelines, and it's very, very dangerous.
In 2022, you write an editorial looking back at your 30 years of guiding it. And you in that editorial divided it into sort of three periods. Can you tell us a little bit about how you saw the journal evolving over time?
Over the years, we collected a number of clinical investigators who were very independent, who had ideas that were very important but didn't find room in mainstream journals and so on. And we continue to do that to the point that a few years ago, we reached an impact factor which was above the American Journal of Psychiatry, which was really a paradox because American Journal of Psychiatry is extremely powerful in terms of investment and so on. And so we were this small group of people doing that. But things were changing in the world of publishing because the open access issue became more and more prevalent, and the fact that publisher wanted to have a say in the papers that they publish, and also in Karger, because at a certain point we had Thomas Karger's retirement, and everything changed in the company. In my opinion, it changed for the worse. 3 years ago, 2.5 years ago, I decided that, I've been editor for 30 years, and yes, I could have continued, and everyone was saying, okay, please do it, because the time you resign, everything will be over in a way, which was true, I must say. But I decided, why don't we try to continue with the two associate editors were working with me, and this is what we did. And I remain as honorary editor. But there was a big difference in the terms that we no longer had a publisher who was proud of what we were doing. We had a publisher who was concerned about other matters and didn't care about the impact factor in what we were doing.
What were the other factors that it was concerned about now, the publisher?
In general, publishers now want to have a saying in the editorial line of a journal, and for instance, inviting papers. The field has changed so dramatically. You see, when I started in the 90s, yes, there were some ghost-written papers, but we could really recognize those, and they were limited. Now you have a tremendous number of papers that are totally ghost-written. Let me give you just an example. I acted as a reviewer, not as an editor, to a respectable pharmacology journal, and I, in my review, I objected that this paper was commissioned by a drug firm, written by a medical editor, approved by the authors, who had major conflicts of interest concerned with the product that was discussed in the paper. Don't you find anything which is odd? And the response of the editor was, they disclose all these issues.
As if that removes the conflict.
Oh, yeah. And the idea of making money. Thomas Karger's philosophy was that of the subscription-based journal, which is the best for.
There are those two funding sources, open access where people have to pay, or journals where they're basically funded by pharmaceutical advertisements. With the subscription base, it's basically funded by the readers.
Right. And the libraries. A couple of decades ago, publisher found out that libraries were not willing to accept new subscriptions to new journals. So there was this idea, let's have the authors pay for the journal. It's like if we go to a restaurant, we bring our own food, we go to the kitchen, we cook the food, we bring it to our table, we eat it, and we pay the bill. That's the open access. The point is to make a financial threshold for reporting certain things. Let me give you a personal example. In my career, I reported for the first time certain side effects. For instance, withdrawal effect with sertraline, anterograde amnesia with zopiclone, and other things. Of course, I don't have any grant.
Gonna pay for that.
I could probably get a grant for not publishing. And I know of a lot of psychopharmacology investigators who were paid for not publishing certain findings. So it's important that we don't have that financial threshold. So things change in the world of publishing, and Thomas Karger was for subscription. The new management is leading to open access. Open access, you publish anything, and then there was the next step, predatory journals.
So basically, with this switch in publications, it wasn't so much necessarily that they were against some of the content, but it just wasn't a model that produced the revenue they wanted to see.
Yes. So what happened is that there were problems between the editors, the publishing house, and suddenly the two editors were fired. Actually, one had decided to leave and the other was fired. And so at that point, I was not even informed of what was going on. And so what happened is that I wrote to the editorial board and say, okay, this is what's going on. I'm resigning. What are you going to do? And most of the editorial board resigned. And then Retraction Watch reported that this added to many other events that occurred in the world of publishing in the past years.
I have really three quick questions. Why wasn't the publisher, since you had such a good impact factor, why wouldn't that be, even from a financial point of view, a reason to continue along this same line, being a home for the type of research you've been publishing for 30 years? It seems to me if I'm the publisher and I have a journal that's getting such a nice readership, I want to continue with the editorial content that brought that readership in. Why don't they see it in that way?
Well, you see, the way you're reasoning is the way Thomas Karger was reasoning. It's not the way that that is done, unfortunately, these days. So it's more than having a certain direction, going to open access, making more money out of scientific journals. The money you make with subscriptions, of course, with exceptions of journals that sell thousands of copies, is limited. With other methods, is really big business.
Two things. What's going to happen? Is there any way to save psychotherapy and psychosomatics, or is the change happening and you got a new editorial direction and you'll just have to see what happens? Is there anything to save here, so to speak?
Unfortunately, I don't think so. A thoughtful publisher, if we have the revolt of most of the editorial board, you would consider that, but they didn't. They didn't. So of course there will be a new editor. Right now, the journal is run by a managing editor who has no competence in the field, and it comes from Frontiers, the company that open access company. He has been hired a few months ago just to run the journal, and then they will appoint a new editor. And what they're looking for is someone who will follow directions. I'm sorry to end this conversation in a little pessimistic way, but I think that the 30 years, someone said the golden years of psychotherapy and psychosomatics are gone. Something that has been very impressive to me is that there were hundreds of protests outside of the editorial board for what went on with the journal. So I don't know, maybe, but the new management of Karger doesn't seem to be affected by those protests. But if you keep on receiving complaints about what has happened, I don't know. It may sort out certain effects, but right now, I tend to believe that the experience of psychotherapy and psychosomatics is over. And I don't even see any replacement. And I think it's really a major loss in the context of the progressive loss of intellectual freedom. But Bob, what you're doing is very, very important because you keep on talking about issues that are important and are vital. So we never give up.
Okay, well, that's a little bit of optimism. I have to say, personally, I feel it's an extraordinary loss. I don't know another journal that has served as home for independent thinking and skeptical thinking. I was counting up the number of times we've referenced psychotherapy and psychosomatics on Mad in America the other day. It's like 126 references. And we have this financially fueled narrative and guild fueled narrative, which is always saying how great everything is. And then we had your journal that was really rooted in clinical experience and really a home for other people, which is such a vital part of any sort of understanding of a medical treatment. And it was, as you say, in a larger sense, a place for independent thought, freedom of publication. And now we're losing this within psychiatry and psychology. I don't think publishing is changing only in this particular discipline. It's the problem is broader. But I will tell you, when I first learned about this, I was thinking of writing a blog with the headline, "Now we're all screwed," because we're going to lose this fountain of information. And yes, Mad in America, we do try to make this known, these clinical experiences known, your findings known. But one of the things we do is we're not inventing this stuff. We're relying on what appears in your journal, for example, and every once in a while articles in other journals. And yes, we always privilege personal stories because personal stories tell of clinical experience. But I can't tell you what a loss I think to society, and especially when you think about how big a place psychiatry now has in society. It's a loss to public health. It's a loss to medical integrity, scientific integrity. What you accomplished over 30 years, I will tell you personally, I'm grateful for. It changed my life just because it presented information that I could report on. And to lose that is just crushing. That's all I'm going to say. It is just crushing to lose psychotherapy and psychosomatics.
Yeah, but at the same time, let's close with something more sort of optimistic. It was also an experience that we can do certain things. As if we have a publisher that is going to support independent thinking. For instance, I'm positive that if we had a publisher, a subscription-based publisher that was willing to invest on this, things would continue. At the time being, we are stuck. Let me close with this. I must say, one of the admirers of the journal has been Noam Chomsky, who wrote an editorial for us saying how it is important when you find something that you don't like to write it down. And so the teaching remains. I've been concentrating as the editor, but behind me, there was a group. There was a fantastic group of people first-class scientists who supported all this work. And I hope that this group with a new editor may find a new home.
Well, it's good to close on an optimistic note about what is possible. You did have it was a place for a gathering of a community of scientists, for sure. So let's think about an optimistic future then, possibilities. And Dr. Fava, thank you so much for joining us today.
You're very much welcome. And thank you for giving this opportunity.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.